Hello everyone, today I want to talk to you about the various forms of shock. This chart that you see in the top left corner is a basic chart. Probably find it on Google and various other sources. Basically it tells you how the various forms of shock lead to a physiological response in the form of some form of compensation. So before we begin, I think it's important to review the responses that occur in the form of adrenergic stimulation. So over here, I've written epinephrine is equivalent to various states. So essentially, when epinephrine is within a low dose versus a high dose, the response that it has on the vasculature, primarily in this instance, will be different. So under a low dose, you could call it a tonic secretion. So your baseline secretion of epinephrine, it will stimulate beta 2 receptors. And so what that basically means is there's going to be dilation. And then in instances where there is high levels of epinephrine, primarily we're talking about the vasculature here, it is going to stimulate alpha 1 receptors. And so the response based on the concentration of epinephrine that is released is going to have a different effect. And this is important because if an individual is in fact in shock, this is considered a quote unquote stressful situation, right? So that stress is indicated by the levels of epinephrine and the physiological responses that occur downstream to it. So in shock, we're going to have stimulation of alpha 1 receptors within the vasculature, which is what I have written here. So alpha 1 receptors are going to be stimulated, and as a response of alpha 1, there's going to be a clamping down, therefore a constriction. Additionally, when we look at the heart also has various forms of receptors, beta 1, 2, and M2 receptors. So beta 1 and 2 are indicated by the sympathetic nervous system, and the M2 implies the parasympathetic nervous system. And so in this situation as well, if there's going to be stimulation of the sympathetic nervous system, there's going to be an upregulation of the betas, or not upregulation, but there's going to be an upstimulation. So there's going to be more of a sympathetic response, and there's going to be a reduction in the parasympathetic response. And the way that we're able to determine that is by looking over here. So essentially, this is the heart. This is going to be the aortic arch, the ascending and descending. And then here we're going to have the common carotid arteries, and then the subclavians, right? And so this is the branch point for the internal and external carotid. And here in red, what I've indicated are the carotid bodies and then the aortic bodies. And so essentially in these areas, there's going to be detection of pressure. So they're baroreceptors, right? So when preload comes into the left ventricle, there's going to be contraction of the left ventricle, then leading into the ascending aorta, then into the aortic arch, where the aortic baroreceptors will detect whatever pressure is being emitted. Likewise within the carotid systems as well. And so this is important because it is these specific areas that are going to facilitate whether or not a sympathetic or parasympathetic response occurs. And it usually goes in the same direction as that of the cardiac output. So what I mean by that is if cardiac output, so if there's an increase in cardiac output, essentially what we're also saying is that there's going to be an increase in pressure within those specific areas. And so if there's an increase in pressure, there's also going to be then an increase in firing of those baroreceptors. And so if there's an increase in firing, basically what we're saying is that there's high blood pressure, right? And so the body wants to reduce it by decreasing the sympathetic nervous system and by increasing the parasympathetic nervous system. That's in the case of when it's increased but basically the point is that when there's increase in cardiac output, there's going to be an increase in firing, and likewise the reverse would also be true. Therefore, if there's an increase in cardiac output, there would be an increase in firing, leading to an increase in sympathetic nervous system, which is the more important aspect of this, and there's going to be a decrease in the parasympathetic nervous system. So now that we have reviewed this aspect of it, now let's begin talking about the various forms of shock. So to begin, we're going to be talking about cardiogenic. And so the first question would be, is what brings it about? So what is the primary disturbance that leads to cardiogenic shock? And so here I've listed some of the various forms, so myocardial infarction, heart failures, and valvular dysfunction. Essentially everything occurs at the level of the heart, right? And so if there is a problem with the heart, what we're also then saying is that the effectiveness of the heart to pump would be reduced. And so if the heart is unable to pump properly, another way to verbalize that would be to say that there's going to be a reduction in cardiac output. With a reduction in cardiac output, there's going to be a reduction in the pressure that the heart is able to create. With a reduction in pressure, there's going to be a reduction in pressure within those various forms, various places that I've indicated here, implying that there would be then a reduction in firing of baroreceptors. Because there's a reduction in firing of baroreceptors, the body is going to detect that and increase the sympathetic nervous system response. The sympathetic nervous system response will then affect multiple areas, but two areas that we're going to be looking at. Essentially, it's going to be the blood vessels and the heart itself. So within the blood vessels are not just one singular entity, but actually several, but we're looking at arteries and the veins. And within the heart, also, it constitutes a few different portions. It's going to be the electric and the muscular portions of it, right? So there's going to be the SA and AV node and the myocytes, right? So when the blood vessels get stimulated by adrenergic stimulation, what's going to happen is there's going to be constriction, both in the arteries and the veins. I'm going to move this. There's going to be constriction of both the arteries and the veins, right? So by constricting the arteries, we basically increase the afterload, and by increasing the afterload, another way that we can write that is to increase the systemic vascular resistance. So essentially, what the heart has to pump against has increased, and the reason why we want to do that is so that the heart essentially has to pump harder, right? So we're forcing more blood kind of back in there, allowing for further expansion, allowing for stronger downstream contractions. And then in the venous system, by contracting the veins similar to that of the legs, due to, for example, the muscular pump that occurs within the veins because of the valves, by contracting the muscle, what we effectively do is push the blood back upward. And because we're in the venous system, by increasing the blood to return back to the heart, we're increasing the preload to the right side of the heart. The preload to the right side of the heart is called the central venous pressure, right? And because we are in a closed system, according to Bernoulli's laws of fluid dynamics, anything that comes in has to come out, in addition to any alterations in pressure in one area would affect another area of the body. So if we have increase in the amount of blood coming back to the right side of the heart, we expect there to also be an increase the amount of preload to the left side of the heart, and that is going to be expressed as the pulmonary capillary wedge pressure, right? So effectively, we have explained these variables. Now let's look at what happens in the heart itself. So upon beta stimulation of these different nodes, we're going to have an increase in the heart rate, and when we stimulate the myocytes, we're going to have an increase in contractility. We're going to have an increase in heart rate and contractility. So when we say that an individual feels cool to the touch, right? So why is that? So there's various reasons, well, various processes that are occurring. So and when there's shock, the body is focusing more on the organs, more on the axial organs, right? So everything that occurs along the, I guess, the core of the body, so the heart. So we're trying to keep the heart and the brain perfused to the best of its abilities. And so what we have is a mixed response. So the skin the receptors in the skin becomes clamped, and so the individual feels cool, but then also blood supply to the extremities also becomes clamped, right? And so the individual feels cool. So just to further go over, so we have a decrease in cardiac output caused by any one of these reasons. The reason isn't too important, just the fact that it occurs within the heart. We have a decrease in the pressure. That pressure is going to be detected by the baroreceptors. As such, there's going to be an increase in sympathetic response. Additionally, there's also going to be a decrease in the parasympathetic, but it mirrors essentially what's going to be happening here, just in the reverse. So instead of there being more of a, the classic example of a person driving a car, right? Always within physiology, it's either a person is pushing on the gas or pushing on the brake, but in physiology, it's usually a mix of the two, right? So by increasing this, effectively, what you also are saying is that you're reducing the amount of parasympathetic input a little bit. So you're not completely reducing it, or not completely eliminating, but you are reducing it to some extent. But focusing just on the sympathetic nervous system, on the blood vessels, we have the arteries and the veins. There's going to be constriction of both. Constricting the arteries is going to cause an increase in systemic vascular resistance, therefore having the heart squeeze harder, which is what we want because we have a decrease in cardiac output, decrease in pressure within the aorta, therefore a decrease in the blood pressure overall. In the veins, we have constriction as well. Constricting these veins actually pulls blood back to the heart, and by doing so, we're increasing the preload back to the right side of the heart and then the preload to the left side of the heart. At the level of the heart itself, specifically to the heart itself, we have an increase in heart rate due to the fact that we're stimulating the nodes, more specifically the AV node, because the AV node, the refractory period, is what determines the heart rate itself. So more specifically, we're just increasing the heart rate. And then on the myocytes itself, we have increase in contractility, all leading to try to restore the drop in cardiac output. So essentially, we're looking at two systems of blood vessels and heart and how they respond. Now let's take a look on hypovolemic shock. So hypovolemic shock is essentially saying that there's a reduction in the blood volume. So it is not to say that the blood is necessarily in the system. It could have been excreted in some form or left the body. So for example, If a person has chronic diarrhea or vomiting, or really anything that reduces the blood volume, the amount of content within the blood will also then be reduced, right? So so let's take these areas for example, right? So this first one would be under normal circumstances, right? So the luminal diameter is whatever it is. Let's still just say that the diameter is 10. Arbitrary number, doesn't really matter, but let's just, for argument's sake, say it's 10. An individual has some sort of disturbance, so he has hypovolemia, and now the luminal diameter is reduced, let's say to 5. Again, doesn't really matter. And now the body wants to respond in some way, and then we'll get back to this last circle. So now let's view essentially the equation once more. So we have the blood vessels. We have the blood vessels, right? And again, let me just quickly draw this out. Okay, so in hypovolemia, what's going on is that there's going to be a reduction again in cardiac output because there's less stuff in the blood, so the volume that's found within the vascular system is reduced. So just logically, we can say, and it is the case, is that there's going to be a reduction in cardiac output. Because there's a reduction in cardiac output, we're going to follow the same logic as before. It's going to affect the pressures, it's going to affect the baroreceptors, eventually leading to an increase in the sympathetic nervous system response. The sympathetic nervous system response is going to then trigger the blood vessels and the heart. Now, in the blood vessels, what is going to happen? It's quite interesting, actually. So in the arteries and the veins, we expect still the same thing as before. We still expect there's going to be constriction. Likewise, in the veins, there's going to be constriction. However, the response is now a little bit altered, right? So because we already have hypovolemia, so that already means that there's a reduction in luminal diameter. The response to cause a constriction will essentially do what? In the arteries, it will do, as what we expect, there will be an increase in systemic vascular resistance, so increase in afterload. However, in the veins, because now the veins are also constricted, so over here, now because it's already been reduced, now it's being reduced even more, so the compensation to the veins actually causes a reduction in the amount of blood that returns to the heart. So the central venous pressure in this instance actually becomes reduced. And likewise, if there's less blood returning to the right side of the heart, there's going to be less blood returning to the left side. And so the pulmonary capillary wedge pressure will be reduced. So we have a reduction in both the central venous and the pulmonary capillary. In the heart, similar phenomenon will occur in that there's going to be beta stimulations. And so we're going to have increase in heart rate, increase in contractility. That aspect pretty much doesn't change. And so let's quickly go over what was said. So initially, we have something that's normal, it looks like this, arbitrary number of 10, luminal diameter. And then there's some sort of disturbance of some sort of hypovolemia, the luminal diameter is reduced. And then in the form of compensation, so this is where the compensation occurs. In the form of compensation, the luminal diameter is even further reduced. However, for the arteries, that's fine, we expect that to happen. In the veins, the opposite effect of what we want actually occurs. So we have a reduction in central venous pressure, indicating that there's less return to the heart. Likewise, there's going to be a reduction in pulmonary capillary pressure for the same reason. Less blood coming in, less blood can be leaving. And then in the heart, as we expect, there's going to be an increase in heart rate and in contractility.